Hello, everyone, and thank you so much for your patience. We're running about 12 minutes late, but we sincerely thank you for your patience. Some technical issues. We thought the end of technical issues was in sight, but we finally made it. And thank you, Dr. Lucas, for your patience. But it gives me an absolute warm, it's a very warm welcome tonight to everyone for joining us. I'm not going to give any further introduction because this man certainly doesn't need any more. He is a leading paediatric dentist in Australia and globally. So Dr. Lucas, the floor is yours. And if anyone has any questions, please post them into the questions section in the top of your screen. Thank you so much.
Thanks, Danny. Danny and I are working as a team tonight because she has to press the buttons because of our technical hitch. And we will go to the full screen now. Yeah. So anyhow, the interesting thing is that dental trauma in the mixed dentition is quite a challenge for a variety of factors. Dental trauma differs between age group. So in the primary dentition, which is on the next slide, you can see that looking at the biologic sequelae of the injury, it's usually upon the developing dentition, which can be manifested in the permanent dentition by enamel hyperplasia or disruption of the tooth formation. The difference is, you can see here where one young child has had an injury, a fall, and the first time his parents saw that, he worked out that he'd had a couple of extra teeth, and this young child had literally degloved their maxilla, which could possibly cause some injury to their permanent dentition. If we go to the next slide, you can see that the trauma in the mixed dentition is quite different. The biologic sequelae is upon the developing tooth, and the dentition with the consequences to complete dental maturation and occlusal development. Because you are in a state where you have everything is growing. Whereas if we look at the next slide on the permanent dentition, is that the biological sequelae is mainly upon the mature dental pulp and mature dental tissues and associated bone, but has no real consequence to the rest of the growing and developing oral cavity. If we then consider the next slide, which is that you have a look of what the considerations and why sometimes treating trauma in the mixed dentition is a source of frustration. First of all, you've got a very much a dynamic environment. You've got a growing child that's going through their pre-pubertal growth spurts and then going into puberty. They are growing both physically and facially. There's a quite significant change in facial dynamic. There's significant behaviour maturity, where you go from a child that's 5 years of age who's gone into the first year of primary school to somebody who's going into the first or second year of secondary school. The dentition is developing from being basically an immature mixed dentition of mainly incisor teeth and first molars to one where you have a complete adult dentition. You have teeth where the roots are incomplete, they haven't completed their root development, and also obviously there's change eruption stages with teeth falling out and teeth erupting. If we then consider what the next slide would be, is that what are the considerations? Because you have a whole variety of things that you have to consider when you're taking trauma management. You have to look at the management of bone because you have osteoclast and osteoblast activity, the management of the enamel and dentine with ameloblast and odontoblasts, management of cementum with cementoblast and cematocytes, and inflammatory cells, which there are many and varied, such as endothelial cells, thrombocytes, erythrocytes, etc. So if we go to the next slide, is that then we can look at what are the different types of dental trauma. And they are many and varied. When you read some of the literature, is that they're always looking about specifically an injury to a tooth. But in many instances, they are multiple injuries, such as the one slide in the top left-hand corner. There's a young guy that went off a trampoline and luxated his two central incisors, lacerated his lip. The little girl fell off her bike and intruded her 4 upper incisors. Another young guy falls off his bike and knocks his tooth out and causes facial lacerations, which all these have to be fitted into the package of repair and care. Similarly, on the next slide, you can see that therefore you can get some bony injuries and soft tissue injuries. You can get this where the labial tooth has been literally knocked forward and labially placed. You can have there where you get complicated crown fractures with multiple injuries and possibility that the tooth is not salvageable. And here's a young kid who fell off his bike, landed on his chin and got a degloving injury, which is a very serious injury, and filled up the whole space with grass. So you can get very severe injuries compared to a fracture incisor or a displaced incisor. Next slide, please, Danny. So if we have a look at what the etiology of the dental trauma is in this age group, the most common thing is bicycling accidents. So if you click the slide again, Danny, you should see here this charming young man where the boys have gone down the park, they built a jump, and he's landed on the end of his handlebars, creating the injury that he has down the bottom. So you can see that dental injuries can be excessive. It can be just a family out on a bike ride, a dog runs across the road, the car goes over the handlebars. Playground accidents are common, such as monkey bars, which is I find fascinating that monkey bars still exist. Trampolines, before they had padding and sides on them, were a source of injury. Where a child, even now, a child can spin around like that last young man, land on his knee and intrude his teeth. Climbing up the slide backwards is fashionable at the moment. Kids coming down water slides in water parks. Go forward again, please, Danny. Going down water slides and in water parks, another source of injuries. And sometimes it can be just stupidity, where you have a child that the most classic stupid one I've heard recently was kids who were playing that game Marco Polo, where you have children in a swimming pool, one is calling out the other's name and they're running around with their eyes closed. Well, these children decided to do it in the school ground wearing their face masks over their eyes so they couldn't see, and this one young girl walked straight into a pole. So there are many varied ways of causing dental injuries. Can we go forward 2 slides? Yeah, next one. Yeah, so what do we work from? Currently, the guidelines that are put out by the International Association of Dental Traumatology available for free online for the management of dental trauma. There's basically 4 papers that cover basically everything from avulsions through to intrusions through to luxations. It and covers them all. Next slide, please. Unfortunately, if you look at a guideline is a guideline. A guideline is based upon looking at the clinical research to seeing and determining what is the most appropriate action for a particular injury. Unfortunately for us as clinicians, no 2 dental traumas are the same. They will always be different. A kid doesn't always come in and fracture his front tooth. Similarly, no 2 patients are the same. So you can have an 8-year-old girl that's injured herself, whereas they have a 12-year-old boy, different levels of maturity, maybe different levels of behaviour at all. They can range from single tooth to multiple tooth injuries. They can involve different tissues such as bone and soft tissues, and they usually don't occur at a convenient time. You don't let Mrs. Smith ring up and say, little Johnny's going to have an accident at 2 p.m. Do you have a time at 3 o'clock for him to come down? It doesn't happen. It's usually when we are running late or we're about to go away on a holiday. Therefore, the reality is you have to interpret the guidelines to fit the case and not try to make the case fit the guidelines. So therefore, in the mixed dentition, we also have to consider that with a long-term dental future of the child, consequently, there must be a short-term and long-term plans. And the short-term plan should not compromise the latter, because the latter is basically the dental future of that child. Next slide. So where do we start? So nowadays, clinical management of dental trauma in young children is usually a phone call to your reception staff. The easiest way to get the initial information is to get the parent to take a photo of the injury and send it through to your practice. This allows initial phone advice by your staff and also information on handling the teeth. Also then you have to consider about the management of the other injuries at the time, such as whether the parents or the individuals, if the tooth has been avulsed, can immediately replant it, or what is the appropriate storage medium that they have at their that they can access at the time. So through that initial little conversation, if we go to the next slide, which gives a far broader description, this is based on Dental Traumatology 2008. You also can get from the parents the relative medical history. More importantly, if there's been a loss of consciousness, because then they should be really getting a neurological assessment before their dental assessment. Whether there are other lacerations or skin wounds that could be considered to be managed by you, the clinician, or managed by a emergency facility. Have they accounted for all the teeth? Where the teeth are at the time? We've had people go back and look for teeth in the park after they've come into the hospital. Can they put the tooth back? And if not, how are they going to what they're going to put it in, what have they got as available storage. And also, if their teeth are fractured, have they collected the parts and what they're going to do with those. So your staff can provide that whole information if you have that set up for them at reception. Next slide, thanks, Danny. Then when they come to the clinic, therefore, you have to take in the clinical management, which is basically going over a lot of that detail again. Basically how the injury occurred, because that may give you an idea of what the fractures or the displacement of the teeth are. The time of injury, particularly with an avulsion, because as we will note soon, there's a difference between wet time and dry time. The place of injury can have something to do, whether it's in a car paddock or whether it's in a playground or on the football field or in a swimming pool. And again, loss of consciousness and other physical injuries. Whether there's any relevant medical history that you should be aware of, such as cardiac conditions and such as like that, whether their immunisations are up to date, particularly their tetanus injections, whether they have any allergies, and also then visually you should be able to look for other injuries into the circummolar area, soft tissue, alveolar injuries, and accounting for the fragments of fractured teeth. It is not uncommon, well, it is uncommon, but that a fractured fragment can finish up stuck in a tissue laceration in a lower lip. So then you would take, if you were concerned, you would take a radiograph of the lower lip to determine whether there's any tooth fragment there. And then you have to assess the mobility of the teeth and then take radiographs that are appropriate to the types of injury, whether they be periapical x-rays initially or a sort of lateral view film initially, just to get an idea of what the injury is. Next slide, please. So therefore, what you then has to do is work out and how you can structure your approach to the management of dental care. The first issue is the anxiety of the parent and child. The issue that can be related to, this could be the first most significant injury that child has ever had. And it's a severe injury because it affects their aesthetics. Parents are concerned about what's going to happen, whether the tooth are going to be lost. And so therefore you have to placate the parents, provide them with advice, and then structure your clinical approach. Probably the easiest way I find to do that is firstly to take care of, look at the injuries to the bone, followed by injuries to soft tissue, then stabilisation of teeth, protection of the pulp, and repair of tooth structure. Next slide, please. And so therefore, let us consider some of the, or the most common injuries that we will see, and then we're going to describe them through and then look at some cases of how they are related at the end. Firstly, avulsion, which can also be exarticulation. You can see here this young lady decided to fall off a bike and knocked her four upper incisors out. That is complete displacement of tooth out of the socket. The periodontal ligament is severed and the fracture of the alveolus may occur. Diagnosis is clinical radiographic findings reveal that the tooth is not present in the socket or the tooth has already been replanted. Radiographic assessment will verify that the tooth is not intruded when the tooth is not found. And the concerns which we can talk about as we go along, is that if the teeth were related to dry time and wet time, the effects of inflammatory root resorption or replacement root resorption, and how they can be affected by the time that the tooth is out of the mouth. Next slide. So the big debate or big concern is dry time and wet time. Excuse me. Dry time is basically the time that the tooth is not in any form of medium while it is out of the mouth. So if the tooth has been knocked out and it is the replantation of the tooth is usually within 5 minutes, the return of the PDL cells and cement cells to normal function usually occurs. More than 15 minutes of dry storage, the precursor progenitor and stem cells are usually no longer available to differentiate to fibroblasts. And after 30 minutes of dry storage, all the PDL and cemental cells are remaining on the tooth root are likely to become necrotic. Now, this was a review undertaken by in the Australian Endodontic Journal, and similarly done by Peter Day and Terry Gregg in England. So therefore, you think, oh my God, the tooth is cactus if you haven't got it back in the mouth. So we can go to the next slide. So if you're having a look at the effect on periodontal ligament, the cases with short periods under 15 minutes of dry storage show a high percentage of normal periodontal healing at 1 year follow-up. This is a study by Chapuis et al. And only 95% of these, 9.5% of these teeth were replanted with replacement resorption, compared to 38 when the teeth were at 8% when the teeth were out for longer than 16 to 60 minutes. So you're still looking at, if you're looking at odds, and if you were going to be a punter on the TAB or sports bet, some of the odds here are still in favour of getting some periodontal fibres being viable. And also the other thing is there's the ability of PDLs to form colonies, which is called their collagenic capacity, can be affected by dry time and straw time storage. And this study was done initially by Kenny, but has been shown to have different effects with different storage mediums. Next slide. So the storage medium is probably the best storage medium we have is obviously milk. It has a physiological osmolarity between 230 and 270 microohms per kilogram, and it's okay for about 2 hours. If you wish, you can replace the milk again in 2 hours' time. Similarly, it has a pH of milk is in the physiological range. It can provide some nutrients to cells. Pasteurised milk has a low bacterial count, so therefore there's consideration you won't get infection of the pulp. Ideally, it should be refrigerated. Sour milk, because of increased acidity, is not a good idea. And if you have fresh milk, according to Leogu, it should be you should put the tooth in ice in the milk. Some people find different lengths of time. Chilled milk is effective for 1 to 2 hours. Skim milk is felt better than whole milk. Long life milk's okay, doesn't need refrigeration. If no milk, you can use saliva. And there's been studies to show that saliva is quite useful. Ideally, is not to put the teeth in your mouth, but maybe to spit in a cup and place the teeth in there. It adds a very good intermedium between that time and time you can get it into milk, which gives better osmolarity. Next slide, please. Other mediums are, which we'll go through, and each of them can be used if you're desperate. Baby formulas, reconstituted powdered milk, yogurt, but it's usually slightly acidic, Gatorade and contact lens solutions are hypertonic and not good because of their acidity. Soy milk okay. Water is okay just for a brief wash, but you wouldn't soak it there because it basically the osmolarity destroys the PDL cells. And you can go down with egg whites, coconut water, and other suggested things that have been tried. But the reality of life in our society, the best thing to place is milk. And if you're involved in a sporting club, to make sure that they have some long life milk sitting in the cupboard. Next slide, please. So if we're looking at the clinical management of an avulsed tooth, it's like looking at a pyramid. First of all, you have to manage the bone and the alveolar socket. Secondly, you have to manage the soft tissues, including repositioning and suturing. Replanting the splinting the tooth is next. Then looking at protection of the pulp and then restoration. Why in that order? Well, the reality is that if the tooth is knocked out or avulsed out of a socket, there's usually some combination injuries of the socket. You'll get socket fragments that have been, or labial plate fragments, compressed into the socket. So when you're trying to get the tooth back in the socket, it just doesn't go, and you're starting to get a bit stressed about it all. So what then you have to do is the easiest way to do it is get a large spoon and run it around the socket and then redefine the walls. One question everybody's always had, if you're looking at an injury where you've lost labial tissue, is that labial plate disappears. And I till to this day don't know where it disappears to when you have a severe injury. I think it finishes up in the same spot as where all the lost socks go, but I don't understand. So therefore you define your sockets and then you reposition your soft tissues and basically put suturing between the interproximal being the tooth, because then you define where you're going to put your tooth. Then you reposition your tooth and you'll find it'll even suck down into there, and it has to be repositioned accurately into the socket. You can't have it flopping around, because what will tend to happen, you will then get granulation tissue. Then you split the tooth, and then you consider what it has to do to the pulp, whether it's just a temporary covering if there's a fractured tooth, or restoration, but that would usually be done at a later date. Next slide, please. So splinting. The splinting provides us with a bit of a challenge because we don't normally have hunks of bits and pieces all around the place. So you have many options. So you can start on the top right. It's a young boy who fell off in a playground at a display home centre, knocked out both his central incisors, plus his laterals, plus degloved his maxilla, plus made a real mess. So when those teeth were repositioned, there was nothing to splint them to. They had very little root structure, so the only way to do that was to put black silk over the top of them, basically like holding them in that way. Here was a young guy who was in the country, he fell over, knocked his tooth out, was sent down, and in this instance he had this big concrete splodge over the top. Now the idea of a splint is that it should give some physiological movement and it should hold the teeth in the correct position. Obviously this was giving no physiological movement, but once everything calmed down, you could remove the composite and then re-splint the teeth and really assess the injury properly, because there you can't see much at all. The classical one is to use a composite wire splint, where you use a thin sort of 0.16 round wire, or you can use nylon fishing line of 0.3 to 0.25 and splint an avulsed tooth with that into place. That is basically what most people would have in their clinic, be able to splint tooth, or you borrow some wire from your local friendly orthodontist. You can use brackets and wire, The issue is that if you're going to do any wire splints using orthodontic wire, you use stainless steel wires that are passive, because the heat-treated wires have a memory, and if you put the bracket in the wrong spot, they want to take the tooth back to where they are filling straight. So therefore, you are far better off to use a 016 stainless steel wire that are similar, or 014 and still a knife tire. If you can use squarer wires for more complex splints when you've got lack of teeth and you're running a wire from across segments. So splinting becomes quite effective. And how long do you splint an avulsed tooth? The normal parameter is you splint it for 2 weeks, but then depending upon the complexities, if you've had bony fracture, therefore there's a consideration to splint it for 4 weeks. At that 2 weeks time, you then can consider if you need to pulp removal. Next slide, please. So here we have 2 cases of trauma of avulsion that we will show. This little boy here is an 8-year-old boy, slipped on the polished floorboards and avulsed tooth 2-1. His mother dived a bit like Steve Smith in Slips and caught the tooth just about before it hit the floor. And then replants it in, as you can see. Unfortunately, there was a supernumerary there that did not cause any issues. But here we have the tooth with a 4-year follow-up. And you can see that the tooth has survived. And because it's been reimplanted, all the biological cells there that are enhancing the tooth development are still there. And the tooth, as you can see, has developed with some pulp canal obliteration, but it's got good colour and it's stable and it's got good aesthetics. There's no ankylosis and there's been normal growth and normal passive dental eruption with the rest of his dentition. If a tooth ankyloses, what will tend to happen? It will not passively erupt with the rest of the dentition. So that shows a case of when a tooth is put in immediately, as I talked about, filling all the criteria and all the parameters, that then it has re-established itself in its environment. The next case, and similarly we had, next case, the next slide, please. Similarly, we had a young kid the other day who came into our rooms who had literally had his tooth knocked out at school. He picked it up and put it back in himself. That tooth was being amazingly good. Here's a young boy who avulsed his tooth at school. It was stored in milk. And because he came to hospital, there was a delay for general anaesthetic, so it was replanted 7 hours later. It required splinting and stabilisation, and it underwent some, as you can see, I keep going to point at the screen, but I can't because Danny's got it. That you can see on the bottom left-hand slide that it's undergone some degree of revascularisation or a regeneration, and it's undergone orthodontic treatment. And you can see here at the a follow-up at 7, or sorry, when he was older, that the tooth is still there. There's no resorption, there's no ankylosis, and if you look hardly, you could say there's a small area of ankylosis on the mesial. Apparently, at 16, at his final follow-up with the endodontist, Luke Maloney, that tooth is still stable and still there and still fine. So therefore, that indicates that if you're looking at your wet and dry time, the critical thing about a tooth failing is how dry it is outside the mouth. And you can get away with wet time because you have to consider, if you're putting a tooth back in the socket, the periodontal membrane tears, but there's periodontal fibres that may not be left on the tooth, but they may be left on the inside walls of the socket. So you don't know which cells are colonising and forming and stability for the tooth. Next slide, please. So there's been some new guidelines for 2020, between 2012 and 2020, the guidelines have changed. So particularly for teeth that who have not been stored in a physiological medium or stored dry for an extra time is greater than 60 minutes, The old idea of soaking them in 2% sodium fluoride and scraping the ligament off is not recommended because there is no benefit apart from ankylosing the tooth. And particularly in the mixed dentition, that is the last thing you really need, because that compromises the tooth. That then leads to the possibility of infraocclusion or infrapositioning. It also leads to the possibility of having to decoronate the tooth to stabilise it. Starting root canal out of the mouth, that is holding the tooth in your fingers, drilling a hole in the back of it, taking the pulp out and putting, say, a dentopaste or something inside it, again, is not recommended. If you're going to take the pulp out, take it out once you've got the tooth in the mouth, because what you're doing is you're spraying water all over that tooth, so any possibility of any periodontal ligament being available is gone. If you're handling the tooth, it can be done with using the storage medium to scrape it around, or to use some sweat and gauze in the storage medium to wipe the tooth out. And ideally, people are suggesting that if you use LA without a vasoconstrictor is better, because the vasoconstrictor may delay healing. If you wish to see those guidelines, you can find all the changes to guidelines, you can find them in dental traumatology. Next slide, please. Now, if we're having a look at what's the next sort of thing, injuries that you can have is fractures that are associated with dental trauma. You can have this one where you've got fractured teeth, labial plate fractures. You can have root fractures, and that severity depends on whether it's the apical, coronal or middle third. Bony fractures, which are fractures of condyle and the symphysis through the crypt of the cuspid, and fractures of alveolar bone and labial plate. Next slide. So for enamel fractures, evaluation includes the amount of tooth loss, tooth structure loss, whether there's pulpal involvement, the assessment of any fragments retrieved, and radiographic evaluation of radicular development, that is maturity of the tooth. Restoration can include reattachment of the fragments, pulpal protection, and management of the exposed pulps, such as using a sphecpulpotomy. So it is a complex area within its own framework. Next slide, please. So if you're looking at the fractures of enamel and or dentine only, complications can be due to a lack of eruption. There could be a subgingival fracture, particularly when an anterior tooth is split and it tends to slide palatally subgingivally. Fragments are not retrieved or partially retrieved. As we talked about, pulpal protection, reattachment of fragments, composite resin reconstruction, and sometimes because you have a fracture line below the gingival margin, your consideration of orthodontic extrusion to bring the tooth down so you can expose the fracture line. Next slide, please. When you have fractures of enamel and or dentine with exposed pulp, as you can see, this young person has got a number of those. You have to look at the size of the exposure, maturity of the tooth, the apical development, whether there's loss of vitality, which is an interesting discussion in itself. When is a tooth vital or viable? So in this instance, you would consider revascularization, pulp regeneration, sphecpulpotomies. Not each tooth that is exposed, such as those on the slide, needs to have the pulp removed. The studies done using Memoir Sphec's technique have done it on teeth who have been out of the mouth for up to, have had the pulp exposed for days and weeks, and there's been quite successful. There's a recent study done at the university, the Sydney Dental Hospital out at Westmead, where they looked at their results using pulp techniques, and I think they had 70% success rate using a Sphec style pulpotomy. Next slide, please. So can cone beam be valuable in assessing dental fractures, and how you assess them and what can't do. Normally you would take a periapical x-ray to determine where the fracture is and then try to assess where the fracture line is. The cone beam is the benefit is it determines exactly where the fracture line is and what the fracture prognosis is. Here we have a little girl that went up a metal slide while walking up backwards, fell face first onto the slide, and obviously has fractured a tooth. There was no loss of consciousness. There was no other soft tissue injuries. The interesting component about neither of these mobile fragments, these fragments were mobile. With these injuries, you normally assume the palatal fragment is mobile. So therefore, the one at the back should be the one that would be moving and going around. The other complicator is they're going away for a 2-week skiing holiday in 2 days' time. So the question was here, one, what do you do? And we assumed that it was the palatal fragment that was fractured, but for some reason we decided that we would collect a cone beam X-ray. Next slide, please. Now, if you can see here, you have the graphic down the bottom of the tooth fracture, but if you go to the slices, and you can see on the upper left of your screen on the incisor tooth, which is the 2-1, you can see the fracture line running on the labial. So that is a very unusual, and it's right on the edge of the pulp. Similarly, if you have a look on the right-hand side of the 6 images there, and if you look at the top one, you can see there's the fracture line, and it is running probably 2 to 3 millimeters below the labial bony margin. And if you follow the slides down, you can see how it's separated from the tooth. Question is, what do you do? Which is a really good question. One, I think in this instance, what we did is we bought time. So we worked out that we could reposition the fractures really very closely, the fragments really closely. We were able then to etch around the periphery of the teeth and bond the 2 halves together. And then to watch and see what maturity happens to the tooth, whether we lose vitality, whether we get infection. And in the long term, hopefully with some passive eruption, that bony margin may come further down. And then in the long term, if you want to then do something really aesthetic, you may need to expose the margin. Or long term, if we can hold onto the tooth long enough, as we explained to the parents, it may need to have some implant replacement. But that tooth, as we've seen that now on a month and 2 and 3 months review, that tooth is still very stable with the 2 halves stuck together. No sign of infection, no sign of inflammation, and no sign of pocketing. So you can allow the tissues to try and heal themselves. Next slide, please. Similar if we look at root fractures, which is the same sort of thing. What's going to happen in a root fracture in an immature mouth? First of all, you evaluate the root fractures. We've talked about slightly already. You look at the level of fracture, the amount of interfragmental space, the mobility of fragments, and you can have vertical fractures. You can have a tooth that splits straight down the centre. Doesn't happen very often, but does happen. And if you consider the literature about vertical fractures, they say just forget it, just take it out and worry about it another day. Additionally, you can have radiographs from 2 different angles, so you can determine where the root fracture is. Next slide, please. And it can be a little bit like a jigsaw. So therefore, what are the positive factors affecting root fracture healing? Age of patient, immature root formation, positive pulp sensibility, a positive for pulpal healing and hard tissue repair. Non-mobility of the coronal fragment with healing progressively worsens with the great gap of the increased millimetre diastasis between the fragment. Hopefully it doesn't exceed 1 millimetre. Girls show more hard tissue healing than boys. The further the fracture is coronally, the worse its prognosis. And splinting is only in only displaced cases along 4 weeks does not prove a benefit. So next slide, please. So therefore, the types of healing that you get in root fractures are, in A, it just shows that the root is fracture and the tooth is the coronal bit slightly extruded. In B, you can get healing with hard tissue or dentine and cementum shown there. In C, you get healing with interposition of connective tissue, PDL. In D, you can get bone that's imposed in between. And E, you get non-healing and you get granulation tissue. And in that instance, that's when the white teeth tend to fail. Now, here's to next slide, please. Here's two sort of quirky cases of root fracture. This is a young girl who we saw was sent to us by an endodontic colleague who tried to reposition the tooth. It had been, that gap had been like that for a long while, and mother would be classified now as a helicopter mother, but she was pretty intense about doing something and not taking the tooth out. So what we then did is then we repositioned the tooth, and we put this time we did use a Naitai wire to intrude the tooth. We intruded the tooth, it was stable, and then fortunately they were going to New Zealand to live. So it meant that we had success and they were disappearing away. Next thing is we come back about 2 years later and they are in our book, and with fear I was wondering what had happened to this tooth. But at that stage she was having orthodontic treatment, and you can see the tooth here has got it's healed, and it looks like it's healed by cementum and dentine, and this would be because it had a very broad and wide open pulp canal with a lot of viable cellular change going on. And there you can see after the braces have come off, the tooth is still there. So therefore, if you use the healing capacity of the tooth and do that first, it may lead to a very successful outcome. Similarly, in the next one, which is just a very sort of quirky case. Next slide, please. This young guy was in 1983. He was a patient of my then partner's, and he'd had a fall at home in the spa. I was at a religious festival, the football club barbecue, and then I got a phone call if we could see him. So anyhow, he has this vertical fracture going straight up the middle of his tooth, two parts both moving. So again, not much to do at night, we bonded both halves together. Just ran composite subgingivally from the palatal to subgingivally on the labial. And you can see a year later, we're still getting root development. In 1985, I nearly got an apex formed. In 1989, my partner then did the endodontics on it, and in 1993 he put one of his farm posts down the tooth. But that tooth survived, as far as I'm aware, another 10 years because the kid was then an adolescent, went off overseas, but through his parents the tooth was still in his head. So the reality is we should have taken it out, but the reality is he's now he's got a lot older, but he would have been then at an age where if it did fail, he would have been able to have an implant put in without sacrificing bone or having to do anything too exotic. Next slide, please. So you can have alveolar fractures can also be associated with intrusions, compression, which are compressions injuries, obviously avulsions, luxations with labial plate fracture. So the management is assessing the degree of the alveolar fracture, decompressing and reshaping the tooth socket, repositioning the labial bone with consideration of tooth position, and evaluating the outcome to the type of injury. So we have this young girl here that was playing at home with her sister as they were moving house. They were bouncing around on a mattress. She had had orthodontic braces put on to extrude this said tooth down into her mouth because it had been impeded by a supernumerary, so it was being pulled down to the mouth. They were playing on a mattress. It got caught and literally got pulled up, as you can see, like that, taking the labial plate with it and just lying out like that. The guy here is another trampoline injury, and therefore you can see how that's been displaced, and that's quite a simple displacement. Now, if you're repositioning these teeth, particularly the one down the bottom, is that when a tooth gets pushed down and it gets palatally, the root tends to go labially. And if it fractures the labial plate, it can get hooked over it. And if you're trying to push it up, it goes nowhere. So then to reposition, you have to gently pull it out and push it back into the right socket. Next slide, please. So this is a 10-year-old girl that was undergoing orthodontic treatment and got caught in the stitching. She finally saw the clinician, which was 3 hours after the injury. She had labial plate fracture, no other injuries. The tooth was positioned into the position that it was extruded to, not to the position where you would surgically reposition it to. Because then the aim was that then it would heal up in its own environment and not in just a sea of mush. Once the tooth stabilised, orthodontics continued and endodontic treatment was happening. So that's, you would say, okay, that's quite a successful treatment. How long did it last? Next slide, please. So if we have a look at it there with the endodontic treatment in 2006, 2009, and last year in 2021, that's 15 years post-trauma. The root canal still looks quite reasonable. The tooth has discoloured, obviously, could need to be bleached, but that doesn't concern her. She would probably, and is considering having some form of veneer put on the tooth. But that tooth has been successful now for 15 years. So you consider that by utilising the environment to your benefit, you can get exceptionally good success. Next slide, please. There we go. Okay, the other interesting problem that you have are dental intrusions. These are probably the most severe dental injuries. The incidence occurs in 0.5 to about 0.2% of dental trauma injuries, and it occurs due to the axial impact driving the tooth into the alveolar process, and it results in an extensive injury to the periodontal tissues and pulp. So these in immature teeth can be quite a significant problem, particularly when kids fall onto steps and things like that. Next slide, please. So what is the sequelae of intrusion? There's root resorption with a high risk of inflammatory replacement resorption. There's a marginal periodontal bone breakdown. You can get pulp necrosis and ankylosis. What are the treatment options? You can consider what they say is spontaneous eruption, orthodontic repositioning, or surgical repositioning. Now, which of these is the most appropriate for a child in the mixed dentition where you're trying to maximise their dentition? Surgical repositioning, whether you like it or not, will always result in ankylosis. There is no way known that it won't, because you're putting it into a position where there's just a collection of cells that are just going to hold it there. So really, next slide, please. So really, you can consider the two options for in the mixed dentition, and surgically repositioning, I think, is not one of them. Firstly, if they're mildly intruded, you can monitor them for spontaneous eruption. And then you might get re-eruption. To get a tooth to re-eruption, usually it has to be in the same axial plane that it was before, so it comes down into the socket. Primary teeth will spontaneously erupt, but if you just leave them, they'll never come down into the position they were before. They usually displace one way or the other. If you're looking at moderately to severely intruded teeth, you can monitor for spontaneous re-eruption, and if no movement, orthodontic repositioning. So I will show you two cases now where again where we've done that orthodontic repositioning and got biologically successful outcomes. So if the first case was an 8-year-old boy who attended for a second opinion regarding the intrusion of his 2-1 at a 12 days ago, and the dentist had suggested just to leave it and see what happens. It was reported while he was playing, it fallen off his bed, the family home, hit his tooth on the corner of a bedside table. The patient was medically fit and healthy with no known allergies. The first option was to allow spontaneous re-eruption. The tooth was not in its axial plane to opsonize re-eruption. Surgically repositioning was considered, but would lead to ankylosis and infraocclusion. So orthodontic reposition was planned where the 2-1 would slowly reposition with fixed orthodontics. Parental informed consent was gained. Review appointments were organised every 4 weeks. Periapical radiographs were taken at 2 monthly intervals, and the total course of orthodontics was 7 months in total. And there's been a 2-year follow-up post-care. Next slide, please. So you can see here that we took X-rays in 2 angles. You can see that we're taking it basically just through the anterior section, and then you can see a normal periapical, and you can see there's the tooth. Now, the reality of life is that the labial plate's been displaced. The tooth is well out of its axial position, intruded roughly about 10 millimetre, and there was no sign of re-eruption. And so it was then considered to, or I'm just going to turn on a light, hang on. It's better. So there was no chance of the tooth probably re-erupting. Next slide, please, Danny. So the orthodontic tooth was extruded with light forces. You can see here that brackets were placed on the associated teeth and around to the deciduous cuspids. You can see there's 2 wires here. One is an anchor wire. That is a stainless steel wire, which therefore will stop the other teeth tending to tip towards the midline. And there's an 014 nitide tooth to extrude the tooth. Brackets were initially placed near the incisal edge. Next slide, please. And then once they got good axial movement into the axial plane, you can see that the 014 wire was placed, and then the tooth slowly came down into position. And there you say, well, yeah, it's not too bad. Anyhow, next slide, please. But you can see here that the tooth is finally aligned, and there it is on the lower right. But most importantly, if we go back and we saw that the tooth had a very wide open apex, you can see here that there is a wide open apex. And if we go to the final slide, you can see here that we've had complete radicular development, slight pulp obliteration, but there's no need for pulp therapy. There's no need for ankylosis, no resorption, and it's a very, very stable tooth. And that's 18 months after the original event. So I think that would be classified as a biological success. Similarly, in the next case, another young guy who had intruded his tooth quite significantly. He got hit in the face at school. Again, it wasn't in the axial plane. He got a lip contusion. He got quite a facial laceration that was dealt with by the LMO. There was no loss of consciousness. Again, a non-surgical approach was taken, and again, we had 6 months of treatment. Next slide, please. And you can see here the same combination, the stainless steel stabilising wire, the 014 extruding wire, and the bracket slowly repositioned as the tooth came down. And you can see here at this position here that the tooth is nearly down on the X-ray. And you can see that there's still been change in the root development. Next slide. It's further progressive extrusion until it then has come down into alignment. You can see the root canal again is developing, and for some reason that you get pulp canal obliteration here, but it's a very successful and stable process. Next slide. And you can see here that the tooth has come down on the upper right, but then it decided to go back again a little bit. And this is, I think, possibly because we treated it for a little less time than the previous one. So you can see here on the left side, there's like a little composite button on the tooth. We made him a Hawley appliance instead of putting brackets back on, which he just flicked the wire over the top of it. It pulled it down, and then we used that there as a stabilising retainer. And you can see in the X-ray again, good acceptable pulp canal narrowing, no ankylosis, good mobility, good aesthetics, and again, another biological success. Next slide, please. So with dental trauma also, before we go into the last 2 cases of interest, the most important part is oral care and keeping the area clean. So So maintaining good oral health, because kids are scared to brush their teeth because they think it might hurt, they might disrupt something, may knock the tooth. So immediate care would use a chlorhexidine mouthwash, which to be used at home until toothbrushing is possible, and then maybe using a chlorhexidine toothpaste that's the Curacet. Professional cleaning should be done at review appointments, and the EMS airflow machine is really very good at that because it's very gentle, it gets rid of the debris and it doesn't cause pain or discomfort and doesn't really intimidate the kids, whether they're young or they're old. And similarly with orthodontics extrusion, you have to keep it clean around the tooth so you're not getting debris stuck up underneath the tooth to cause any issues. Next slide, please. I think we're nearly, yep. So here's two cases of where you're looking at a long journey, and this is where treatment of children in the mixed dentition is a long journey, and you have to think at the beginning where you're going to get to at the end. This is a 10-year-old boy who fell on metal cricket stumps at school. The LDO tried to position the teeth and failed. The parents lived 5 hours away from Melbourne. We presented 24 hours after that with the expectation the teeth were going to be extracted. He was extremely anxious, needle phobic, and had dental injuries that were obvious. Was that the 1-1 had a root fracture and coronal fragment extruded, and the 2-1 was extruded with a mesioangular enamel dentine fracture. There was no significant tissue laceration, so the injury was basically compromising the teeth. Next slide, please. So you can see here it's delayed presentation. You can see on the little X-ray there's a root fracture. You can see the intruded central incisor. You can see there's a minor gingival laceration at the back that doesn't require suturing. So the next question is, as we flick to the next slide, is what do you do? Where do you start? First of all, we have acute management of the patient. So therefore, he was treated using nitrous oxide sedation. There was no significant bony injuries, and the soft tissues were not significantly irritated. The bony injuries were basically the injuries from the intrusion of the tooth. We then had to extrude one tooth, and we had to try and reposition the intruded tooth and stabilise it, and then look at pulpal repection and repair of tooth structure. Next slide, please. So what did we do first? Well, what do you do first? Do you manage the root fracture or the intrusion? Do you go away and evaluate the literature, but considering they'd come from 5 hours away from Melbourne, I really didn't have time to do that. Intrusions, as we've talked about, if either surgically repositioned or left alone, have a poor prognosis. And how we decide stabilise the root fracture with immature teeth and no adjacent teeth. So the initial plan is next slide. Is that the initial trauma, you can see there's a root fracture in the open apex. What we then did initially was to put brackets on his, I think went as far back as the C's and the E's, and had a wire that basically intruded the central incisor, the one that had the root fracture. Then after we thought we'd had that in a position, we then, and this time we did use a NiTi wire, we then put a bracket on the intruded tooth and then basically pushed one up and pulled one down because they were having forces at work in different directions. And so you can see here from the initial slide at the beginning that we finally got to the 6-week mark, we nearly had the teeth in the right spot. Next slide, please. So at 12 months, you can see here, he's got his lateral incisors coming through. The endodontic treatment has been started on the central incisor because that was what was considered to be appropriate care at that time. And there's no sign of inflammatory resorption. Everything is really quite stable. Next slide, please. So again, at 18 months, therefore, you can see that the root canal and the 2-1 is quite distorted, so it's had an endodontic treatment, but again at 18 months everything is looking really stable and the root fracture looks like there has been some level of healing. Next slide. So then, is everything what you think it is? And that's what we decided then, to get a 3D scan to see what was going on. And therefore you can see here that the 3D scan, we've got cuts of all the teeth, but if we go to the next slide, the 2 specific teeth that were injured, you can see this is on the top scan is the 1-1 and its root fracture, which you can see there is appropriately healed. And down the bottom you can see that therefore the endodontic treatment is not in the labiolingual component, is a little bit underfilled. But the other thing is there's either been a root fracture if you look closely above the 2-1, or what has happened is that when the tooth's been extruded, the developmental cells for the teeth have been torn away, and what we've had develop over a period of time is a tooth, the remnant of a tooth root. And there was a paper published recently where somebody had 4 incisors knocked out at one particular time, and they all thought that they had been knocked out completely. They had open apices, and they came back a number of years later, took an X-ray of the region and found that they had 4 little toothlets that had started to develop from the remnants of tissue. So there is always biologically active tissue around the open apex end of a tooth. Next slide, please. So here we have him at 10 years after follow-up. He's suffered no more injuries except trying to blow his hand off with a shotgun. And you can see here that he's had orthodontic treatment. His teeth are nicely aligned. Both those teeth are very, very stable. And the consequence of that is that he could have lost one or both those teeth when he was younger and had a very compromised dentition. Next slide, please. This one is just really to show what, when we're looking at short-term for long-term gain. This is a 14-year-old boy who fell with his Barker and Avals teeth 1-1 and 2-1 in 1999. He presented, and at that time, their teeth would have been dry for a significant period of time, 45 minutes according to mum, could have been longer, and they replanted. That's dry. That means that they weren't in milk, they weren't in anything. When they presented to us, his teeth had become necrotic, and obviously due to anxiety, he was referred to be treated with basically nitrous oxide sedation. Complication was that he had ectodermal dysplasia. Next slide, please. So he's missing teeth. He had 4 lateral incisors missing, 4 first bicuspids, 4 second bicuspids, a lower right second molar, and an impacted maxillary cuspid and maxillary cuspids. And he's also referred for orthodontic treatment in 2003. So he had some sort of hit and hope endodontic treatment where you got some level of apexification with calcium hydroxide. The teeth were then sealed with gutta perca, and then, as I said, in 2003 he was referred for orthodontic treatment. Next slide. You can see there that he has, obviously he's got multiple missing teeth, but he's had the teeth have been orthodontically treated and they've been stabilised. The cuspids have been brought down into the position of the laterals. The Ds and Es are still present, and similarly his adult molars. Next slide. You can see then that all the restoratives which completed in 2006. You can see there he's had his 2 central incisors rebuilt to look pretty. His cuspids have been restructured to look like laterals. There's been a little bit of composite added to the deciduous first molars to give them the appearance of Ds. And so therefore we consider that there's a 5-6 year survival time, which for a teeth that have been out of the mouth for 45 minutes is really quite successful. So now he is 24 years of age. And he returned like this. He represented with a buccal sinus above the butt-1-1. There was no pain, no mobility. And what are the treatment options? Well, the treatment options weren't many at this stage, but you could consider basically it was implant treatment or taking them out and having a denture, because there'd be no further real benefit of trying any endodontic procedure, including endodontic surgery. Next slide. And as you can see, there's not a lot of bone around them. And if we go to this next slide, and you can see here on the scans that there's infection around the apices of the teeth, but you still have some labial plate, but you've got quite a significant amount of bone on the palatal. So the consideration was for implants. So why has this been a success? The success is that in the next slide, is that he has got plenty of bone there that where he can have 2 implants in for 2 teeth. Therefore, he gets an aesthetically pleasing dentition. He doesn't have to wear a denture. It'll maintain the integrity of that area to place the implants. It maintained his self-esteem through the whole process of care, except probably wearing a denture, which he didn't like. So it just shows you that if you have a look at the short-term gain back in 2000, we're looking at 222. That is basically 22 years later that we have achieved a pretty good outcome for this young guy. So therefore, if we consider in conclusion is that what are the important aspects of treating kids in the mixed dentition is firstly is you have to think you have to work with nature, not against it. You have to realise kids or children are growing and in a dynamic state of growth and behavioural change. And you must consider all options before treatment and don't go to the biological endpoint before you have to. A tooth doesn't have to be that's been intruded, doesn't have to be orthodontic repositioned on that day. You can sit and plan it and come back and do it in the cool light of day. And also, we should be planning for 10 years ahead for each patient and not for one. So I'd just like to acknowledge Luke Maloney for some clinical material and Associate Professor Philip Zimmet for research material, and particularly Hilary Ho, my Oral Hope therapist, for helping me collate my clinical material and making it a lot easier for me. And thank you very much for everybody out there, and I hope you enjoyed your wine. There we are.
Thank you so much, Dr. Lucas. Incredibly informative.
Thank you for changing the slides.
After all the technical issues, my pleasure. We've had several participants text message to say that was certainly worth the wait. So thank you for hanging in there. It certainly was. Are you okay, Dr. Lucas? I know we've now run over time for a couple of questions.
Yeah, sure.
Let's just bring that up. First of all, for trauma patients, do you recommend they sleep with a splint at night to protect the teeth?
No, not really. No, once the teeth have really re-established themselves, I don't see, unless they're a mad bruxer, I don't see any real point in kids anyhow of sleeping with a splint at night. I don't, if they're kid bruxers, you can get him a soft mouth guard if you're concerned that they're going to displace them. But in the short term, when they're splintered and that, they should stabilise and not need to wear a splint. So I don't recommend the kids wear splints.
What is the current thinking relating to splinting of traumatised mobile teeth or the replaced avulsed teeth, and how does the root end formation affect this?
How does the
what is the current thinking relating to the splinting of traumatised mobile teeth or the replaced avulsed teeth, and how does the root end formation affect this?
Oh, right. Sorry, I understand that. Yeah, well, basically is that if you have a tooth that is got comminution, basically they're moving around in the socket and they haven't been displaced, and they've basically got sort of normal grade 1 mobility, you can review that and assess that. if you have distinct movement in an apical up and down thing, therefore you would reposition the tooth and stabilise it for at least 2 weeks. That's the normal time for an avulsed tooth. That doesn't change whether the tooth has a complete root formation or has incomplete or immature tooth or mature root formation. It's still basically 2 weeks. But the reality is that if you have maybe multiple teeth or other injuries, that therefore there's no real harm in splinting them longer. But the most important thing is to get the tooth into the right position within that socket.
Well, thank you. A couple more questions here. What's more important, viability of PDL or time elapsed since trauma? So in brackets, prognosis.
A lot of people use the phrase guarded. The prognosis is guarded, like you've got a soldier standing out front. I think the reality is that dry time is the critical thing. And the longer that dry time is, the more chances that the periodontal ligament's going to fail. But I would never not put a tooth back in the mouth, even though it's got a long dry time, because there is always, if you look at the odds of, if somebody said to me, you have to have surgery, Jamie, and you have a 30% chance of survival, I'd say, okay. I'm not going to say, well, don't give me the surgery because I don't like the odds. It's better than leaving a gap, because then you have to look at the sequelae of not putting it back, is that you therefore have to have a kid has to wear dentures. Then the kid has to have, because then you'll get that hourglass effect with loss of bone, and then they finish up having to have bone grafts for implants and stuff. So, yeah, so yeah, you put them in and splint them a long time, but you must make sure it's right in the socket. Otherwise, you'll get granulation tissue and they'll just flop around.
Thank you. No, that's perfect. And the person responded saying thank you for that. Now, I hope I understood this correctly. With a horizontal root fractured with a broad gap between, is it ever possible to endo the coronial and leave the apical? I think there's, yep, thank you. I think there was a typo there. To remain vital with the hope of collateral circulation to preserve vitality?
Recently we had a kid that had some trauma, and he had root fractures on his 2 central incisors, and they hadn't been repositioned ideally. So by the time we got to us, they were flopping around a bit, and so then we put brackets on his teeth with an intrusive orthodontic force to push them up as close to the apical root fragment as possible. And because God was on our side or something happened, anyhow, the teeth stabilised, and then we root filled the coronal bit and left the apical section alone. So the apical section would just sit there by itself. But yeah, also the coronal sections were necrotic, so you had to do something about it. But yeah, you can get the tooth back, but you won't get it revascular. Well, I don't know. I haven't even thought about it. If you get it close, you must get, like with that one case of the girl, if you get it close, you must get then some healing component where that you get the cemental forming cells and the odontocytes all working together to seal it all up.
Wonderful. No, thank you. Thank you. Would you replant an avulsed deciduous tooth?
No, no.
That's an easy one.
Well, you're more likely to cause damage to the developing permanent tooth by trying to put it back in. I have parents that have done it. I don't then take it out, but
yes.
Yeah, so no, we don't.
Thank you. No, brilliant, brilliant. And then just everyone saying thank you so much. Best lecture, fantastic. Looking forward to hearing more. So the people that are looking forward to hearing more, we have the pleasure of having Dr. Lucas at DentalCon in April next year in Sydney. There's tickets are selling extremely fast, so we're very lucky to have Dr. Lucas again. So highly recommend that you sign up, and hopefully we see you again in April next year, and Dr. Lucas will definitely see you there.
Thanks, Danny.
Thank you so much. Thank you.
Pleasure.
Have a great night, everyone. Bye.
Bye.